Good evening, friends and colleagues, those who are logged in from India, and good morning, good evening for the rest. Today's lecture is on genetic and acquired prothrombotic disorders. It's a case-based discussion by our esteemed speaker, Dr. Rajiv Pruthi from Mayo Clinic, Rochester, US. He has been with us at multiple occasions, personally in Mumbai, and also through webinars during these 2 years of pandemic. This webinar is brought to you by Mumbai Hematology Group. It is supported by RPG Life Sciences Limited and managed by Perfect Square. I thank Mr. Ajit Mule, Mr. Sudhir Ambekar and the team from RPG, Mr. Kalpesh and their team from Perfect Square, Mr. Yash as well, Executive Committee of Mumbai Hematology Group, our guest speaker, Dr. Rajiv Pruthi from Mayo Clinic, Rochester, all our discussants who are eminent hematologists or hematopathologists, I should say, and you participants for sparing your Saturday evening. Tomorrow morning, we have Dr. Abhishek Kakru from Ahmedabad speaking to us about BCL2 inhibitors, and that will be at 11:30 a.m. And now to introduce our discussants, and we have got some very important people with us. Dr. Jasmina Ahluwalia, Professor, Department of Hematology, PGI Chandigarh. Dr. Seema Tyagi, Professor, Department of Hematology, AIIMS, Delhi. Dr. Ruchi Khanna, Associate Professor, Department of Pathology, Kasturba Medical College, Manipal, Karnataka. Dr. Karthik Vaman, DM Hematopathology from PGI, Associate Professor, Department of Oncopathology, Cancer Institute, Adyar, Chennai. Dr. Jasmita Das, Associate Professor, Hematopathology, All India Institute of Medical Sciences, New Delhi. Dr. Priyanka Agarwal from Department of Pediatrics, Institute of Medical Sciences, BHU, Varanasi. Dr. Aditi Jain from Vardhaman Mahavir Medical College, Safdarjung Hospital, New Delhi. Dr. Vijita Datta from Department of Pathology, ESI, PGI, MSR, Maniktala, Kolkata. Dr. Giri Punja, Department of Hematology, Manipal Hospital, Bangalore. Dr. Prusti from Department of Clinical Hematology, SCB Medical College, Cuttack. And now it's time to introduce our guest speaker. He requires no introduction to the audience. But as we have a large number of audience from multiple countries, let me complete the formalities. He is Associate Professor, Mayo Medical School, Rochester. He is consultant in Department of Internal Medicine, Hematology, and Department of Lab Medicine and Pathology. He is Director, Comprehensive Hemophilia Center, Co-Director, Special Coagulation Molecular Hematopathology Lab. He is born in Nairobi, Kenya. He did his medical schooling in India. Subsequently, he did residency in internal medicine, Milwaukee, followed by fellowship in hematology, oncology, molecular biology, and genetic research at Mayo Clinic. His clinical and research interests include lab diagnosis and management of bleeding and thrombotic disorders. Today, he is speaking to us on genetic and acquired prothrombotic disorders, a case-based discussion. Thank you so much, and over to Dr. Rajiv Pruthi.
Thank you very much for that kind introduction, and I'm quite honored to be among such an illustrious panelist. So without further ado, I will go ahead and share my screen and start the presentation. Let's see. Okay, is my screen projecting okay?
Yes.
Perfect. So thank you again for this kind invitation, and I'm actually quite thrilled to be presenting to such a large audience. And the topic, as stated, is genetic and acquired prothrombotic disorders, also known as thrombophilia. And it's going to be a very practical case-based discussion. Dr. Agarwal introduced me very well, so thank you. And I'll get right to it. So the term thrombophilia, what does it actually mean? It's not really a disease that needs treatment. It is actually a risk factor for thrombosis. So you may have an inherited or a congenital thrombophilia or an acquired thrombophilia, but that does not mean that you will go on to develop a thrombotic complication, but something that certainly needs to be monitored. So on a high level, when you look at genetic disorders, you can broadly categorize them into chromosomal disorders listed here, and I've shown a select few. single gene disorders like the bleeding disorders or sickle cell disease, and then multifactorial diseases like coronary artery disease. And really, venous thrombosis is the prototypical example of a multifactorial disorder. I'm going to add, though, that for many decades, we've always thought of bleeding disorders as single gene disorders. You have hemophilia, that's pretty straightforward. Von Willebrand, pretty straightforward. Deficiencies of multiple factors. But what's coming to the forefront with bleeding disorders is that we see so many patients with a bleeding disorder that is not explained. You cannot make a diagnosis. And the next-gen sequencing studies that have been performed don't consistently find a specific defect in a specific gene. But what we're learning, though, is that sometimes patients might have mild deficiencies of multiple clotting factors, and that might predispose them to bleeding. Just a month ago, I saw a patient with a lifelong history of bleeding, and she's been through multiple centers, and each center finds one condition and says, well, that doesn't explain your bleeding. So finally, when I saw her, I found a mild deficiency of the collagen receptor, factor 13 deficiency, and I think she also has a platelet function defect. However, I'm still trying to sort that out. So I think the point here is for bleeding disorders, we may be thinking of a bleeding disorder, at least a subset of them, as a multi-gene disorder. So coming to venous thrombosis, which is a multifactorial disorder, this lists the inherited thrombophilias that are commonly diagnosed. And what I've shown here is I've categorized them into procoagulant protein abnormalities, anticoagulant protein deficiencies, and I've listed here at least the list price of the test from many, many years ago. We have a reference laboratory, and for teaching purposes for residents and fellows, I downloaded the price for each test to emphasize to the students or the learners that these are not cheap tests. These price lists have been taken down from the website. So when I call our reference lab website and I ask them, so what does this test cost? They say, well, it depends on your insurance. That's another big gimmick. But when factor V Leiden was discovered back in 1996, there was an explosion of research looking at multiple different clotting factors. They were sequenced, they were measured, analyzed. And so I think that it's a good pathway to discover biology of disease, but we've discovered so much with perhaps significant and mild thrombophilias. But the question here is, does it affect your management? It is very important to be very cost conscious and very practical in managing patients, as you will see. Prevalence of these thrombophilias, at least the common ones, protein C, protein S, antithrombin, I use the word common, but I think combined they account for less than 10% of patients with venous thrombosis. Far more common are the factor V Leiden and the prothrombin gene mutation. But even these two conditions are only really prevalent in the white population, vanishingly rare in the African population and Asian population. But you can see that there's a defined percent of people, normal people, that carry these abnormalities. If you look at consecutive patients with venous thrombosis, it's pretty rare to get the deficiency states, but far more common for the prothrombin and the V Leiden in the white population. And then when you look at individuals with a strong family history of venous thrombosis, again, the V Leiden prothrombin, stands out, but then there's a slight increase in prevalence of the combined deficiency states. Far more common and important are the acquired risk factors for venous thrombosis. Patients get exposed to one or more of these conditions on a daily basis. We know that surgery itself is very prothrombotic, and what this graph is showing literally is the conditions on the left panel on the y-axis and the odds ratio of thrombosis on the x-axis. And surgery and trauma stand out as very significant thrombophilias. Now, the good news is that if a patient does develop a venous thrombosis in this setting, That's a provoking event. And after you're done with the appropriate duration of anticoagulation that we'll talk about, the good news is the risk of recurrence is very low. So you can provide them with a time-limited anticoagulation. And then you have listed here a whole variety of other thrombophilias. It seems that liver disease seemed to be protective as opposed to higher risk for venous thrombosis. We won't go into each individual detail, but we'll talk about the definitions of provoked and unprovoked venous thrombosis. So, as I said, there's an explosion of research in looking at every different clotting factor protein that's associated with venous thrombosis. And which ones should you be paying attention to? This was a very nice review by Francini from Italy, who wrote a nice review article categorizing particular thrombophilias into those with good evidence, weak evidence, and those that don't really have much evidence for being a thrombophilia. So I've talked about some of these already. What's surprising is that when whole genome studies were done, it stood out that patients with blood group O seemed to be protected against venous thrombosis, or at least had a lower risk of venous thrombosis compared to A, B, well, the non-O blood groups. That's a really cheap test you could do to risk stratify a patient. And then you have a few other thrombophilias listed here. There's weak evidence, and they're listed right here. I won't read each one of them. And then there are conditions that absolutely lack evidence. We used to do plasminogen assays in our thrombophilia profile here many years ago, and when it was shown to be really not a risk for venous thrombosis, we got rid of it because it was just adding cost and providing no benefit. At least to my knowledge, the only known abnormality with plasminogen deficiency is a condition called lignous conjunctivitis. The methylene tetrahydrofolate reductase polymorphisms, there was an explosion in testing, a lot of research done, providing different risk, odds ratios for venous thrombosis, pregnancy loss. Our lab used to run this assay. I'm a co-director of the molecular hematopathology laboratory, and most of our business comes from our reference lab practice. We used to do 1,200 of these assays a month. And then the evidence for, I should say, lack of evidence for it being clinically significant polymorphisms came to the forefront. And we actually got rid of this test because I don't think it provides much benefit. So I would discourage anyone from ordering these tests ever, except perhaps in conditions where you might have significant hyperhomocystinemia. That may be an indication. And purely to understand the mechanism of hyperhomocystinemia, it does not really affect your management. So let's go to some cases, and I'm going to provide broad cases, and there are some specific cases that I have. So one scenario, which is very common in the US, is testing for factor V Leiden. So pick a patient, male or female, who was tested for V Leiden because there was a family member who was tested and found to be positive. The patient himself has no, or herself has no personal history of venous thrombosis. Now the patient's referred to you. How do you counsel the patient? What do you do with this information? What are the counseling issues that one should at least touch on when you're seeing a patient in this situation? So both for males and females, it's important to discuss the risk of future venous thrombosis. In women, particularly, it's important to touch on the risk of venous thrombosis associated with oral contraceptive use, pregnancy, and postmenopausal hormone replacement therapy. Those are really the three, I feel, the most important aspects you need to be touching on. So let's talk about venous thrombosis. This has to be perhaps one of the best done studies that I can think of. And why is it very well done? It's a case-controlled study, retrospective study. These are patients on whom DNA was collected and archived in our institution beginning in the late 80s and early 90s. Factor V Leiden was not even known to exist back then. What does that imply? Well, that implies that the patient management was not influenced by knowledge of any sort of thrombophilia. So we had this bank of DNA. My colleague, Dr. Haidt, extracted the DNA after V Leiden was discovered. went ahead and sequenced over 3,000 patients and then did a nested case control study. So what this shows is in yellow, you can see patients who were carriers, and then in this orange color are patients who were non-carriers. And you can see in the young patients who were, there's really no difference between being a carrier versus not being a carrier on the risk of venous thrombosis over time till you get to about 60. And that's when there's a divergence of incidence of venous thrombosis. As we know, age itself is a risk factor for venous thrombosis. And then if you are a carrier for 5 Leiden, you have a higher incidence of venous thrombosis with age. I thought this was very well done. So one of the take-home messages from this sort of study is, I don't see any reason to test an asymptomatic individual who's never had a venous thrombosis to test for factor 5 Leiden. When you get older, I still don't see a reason to test the older patient if they've not had a venous thrombosis, because the only reason you would test, if at all, is if they developed a venous thrombotic event. Even then, you have to ask yourself, is knowledge of being a carrier for 5 Leiden going to affect my management? So to put the same data in a different light, if you're counseling a patient by age group, you can see that the young patients have a 0% incidence of venous thrombosis. As you get a little older, it does rise till you get to about 60. Over their lifetime, the cumulative incidence of venous thrombosis is about 6.3% in this study by age 65. So that's factor 5 Leiden. It's not considered to be a very serious thrombophilia. What about in women, pregnancy-associated venous thrombosis? Now, in this cohort, the incidence of antepartum or postpartum venous thrombosis was 0. We had no patients with venous thrombosis. Again, that's why I think this is a very pure study, because we didn't know these patients had been factor 5 Leiden. So their postpartum management was not influenced in any way by giving prophylaxis. Now, there are other studies, I have to admit, that, and each study will give you a different answer. There are definitely other studies that show a higher risk of venous thrombosis, in the peripartum period in carriers of factor 5 Leiden. Because there are many different studies that give you different take-home messages, the American Society of Hematology has put together practice guidelines, and this is taken off their website. I didn't do this study or create this slide. So if you go to this website, hematology.org, and you just search for guidelines, you'll come across actually multiple guidelines, not just this one. So the recommendation here is for women who do not have a personal history of venous thrombosis. The panel recommends the following. So here in this column is the hereditary thrombophilia. And what's interesting is they divided the recommendation based on presence or absence of a family history of venous thrombosis. So in this situation, whether you're heterozygous for 5 Leiden or the prothrombin gene mutation, with or without a family history of venous thrombosis, they do not recommend antepartum or postpartum anticoagulation prophylaxis. Now, protein C or S deficiency are more serious thrombophilias. And what's interesting is they say if there's no family history of venous thrombosis, they don't recommend anticoagulation at all. But if there is a family history of venous thrombosis, at the very least, you should consider postpartum prophylaxis. Antithrombin deficiency, however, I think it is felt that it is a much more serious thrombophilia. So they do recommend antepartum and postpartum thromboprophylaxis in the setting of a family history, but not in the absence. A very important point I want to bring to your attention. You can see these red dots. This is very low quality evidence. So if you're looking for evidence-based recommendation, this is very low quality evidence. If there was evidence, moderate to strong, they would have mentioned that. What does that mean? I think in the end, you really need to counsel the patient. You need to understand a little bit what the guidelines are. And I'm going to give you my bias. My bias is if a patient has antithrombin deficiency, I would prescribe DVT prophylaxis. There may be a risk for venous thrombosis, and you don't know who's going to get it, and there may be some complications of pregnancy. But my bias is to provide prophylaxis. With protein C or S deficiency, it's a little more difficult, but once you're done counseling the patient, I've never had a patient refuse prophylaxis. It's always better to get a lower dose of low molecular heparin during the pregnancy than to get a DVT and then require a higher dose, which complicates the labor and delivery. I'm quite comfortable not prescribing low molecular heparin during pregnancy for individuals who are heterozygous for 5-Leiden or prothrombin. So this is the summary recommendation based on the available evidence, which is low quality. What about a different group of individuals who are homozygous for prothrombin, 5-Leiden, or have a combined thrombophilia? So as I said, venous thrombosis is a multifactorial disease, and individuals, especially the white population, can have multiple thrombophilias. So for the homozygous prothrombin gene mutation, again, low quality evidence in red. And they do say that for antepartum, there's really no formal recommendation. But for postpartum, they would provide prophylaxis for 5-Leiden and for the prothrombin gene mutation carriers. And for antepartum prophylaxis, yes, for this group of individuals. So that's the guideline. And I think our own biases creep into it. And you really need to pay attention to the patient's values and preferences. And it's a shared decision-making process. Let's move on to a second scenario of a carrier for factor V Leiden who wants to be prescribed oral contraceptives. So this study was done quite a while ago in 2006, and it was from the United Kingdom. Because there's a constrained healthcare dollars in the National Health Service, they wanted to make sure that any test or any technology you introduce does play a significant role in patient management. So they looked at whether factor V Leiden testing prior to prescribing oral contraceptives is cost effective. So let's look at the data. We know that use of oral contraceptives puts you at a high relative risk of venous thrombosis. And this is borne out by multiple studies listed here, different odds ratios. There just seemed to be one that was not very significant, but all of them are to the right of unity, suggesting an increased risk, about threefold. We know that if you have factor V Leiden, you have a higher relative risk for venous thrombosis. So what about individuals who are carriers of factor V Leiden and are prescribed oral contraceptives? What is their relative risk of venous thrombosis? It jumps to about 15-fold. And depending on the study, from a low of 5-fold to a high of about 35-fold increased risk. And the studies vary because of study design and numbers of patients. How do you use that in counseling the patient? You could look at that very high relative risk, and you could say, I'm not prescribing you oral contraceptives. And then that perhaps puts the patient at risk for unwanted pregnancy, or if the oral contraceptives are meant for controlling heavy periods, they'll suffer. So it's very important to do the right counseling. My bias, my personal bias is I don't quite know what to do with that relative risk. So let's look to see what the absolute risk of venous thrombosis is. So the study authors looked at, assuming you have, on the high end, a 30-fold relative risk of venous thrombosis. Based on the population incidence in that age group, they calculated an absolute incidence of 0.3% per year. That's pretty low. However, again, take the patient's values and preferences into consideration. When I've counseled women in this situation, I share this number with them. You know, it's 0.3% per year. Again, this is part of shared decision-making process. I've only had one woman say, oh, that's too high for me, I'm not going to take it. The large majority of women that I see say, well, that doesn't seem very high. I'm willing to take that risk because I really need the oral contraceptives. So that's the context to keep in mind. However, the group that did the study in the United Kingdom, after doing the analysis, they said routine pre-oral contraceptive prescribing for factor V Leiden is not cost effective. because of the low incidence of venous thrombosis. I think it was the Dutch that estimated that you would need to screen over 1 million women to save one death. So that's a lot of dollars spent screening to save one death. How much value do you put on that one death is a whole different discussion. Let's look at another scenario of a carrier for factor V Leiden who wants to go on to postmenopausal hormone replacement therapy. So similar data, I've summarized it in one slide. You have your hormone replacement therapy risk, factor V Leiden risk, and combined hormone replacement therapy in a patient who's a carrier for factor V Leiden, again, a high relative risk. But let's look at the absolute risk. Assuming on the high end, 15-fold increased relative risk, that translates into a 1 to 2% per woman year. Now, this is a different burden on the healthcare system. If you have 1 to 2% women in a population developing a deep vein thrombosis on hormone replacement therapy, that's serious. That is very common. So what the folks from the UK said, well, in comparison with no screening, universal screening prior to prescribing hormone replacement therapy is cost effective. Now, why the difference? That's pretty high. You know, it's a lower estrogen content compared to oral contraceptives. That's because the population prevalence of disease in the postmenopausal population is much higher. So that's why this is so common. There are, of course, other issues to consider. What is the risk of hormone replacement therapy for breast cancer, perhaps, and other conditions? That's a whole different discussion. So we've talked about the pre-symptomatic individual and the risk factors and what considerations, at least for factor V Leiden. Let's talk about the incident venous thrombosis and duration of anticoagulation issues. Overall, you need to balance the risk of anticoagulation versus the risk of recurrence if you discontinue anticoagulation in a patient with venous thrombosis. So the scenario here is a 45-year-old female experienced a right lower deep vein thrombosis after knee surgery. It was an arthroscopic surgery. She was immobilized for a week postoperatively and then developed leg swelling and pain, and then was diagnosed as having a deep vein thrombosis. So this is a classical provoked venous thromboembolism. What is the definition of provoked? A lot of controversy, a lot of big organizations discussing what is provoked versus non-provoked. So when you see a patient with a deep vein thrombosis, you have to really classify that patient into provoked versus unprovoked. And in the unprovoked, I'll talk about this in the next few slides, categorizing them into male versus female is helpful. How do you define provoked and why do you need to differentiate? So again, the guidelines that just came out on the American Society of Hematology, it's available on their website. They categorize provoked factors into transient risk factors. In other words, risk factors that resolve, and this could be major, surgery, being confined to a hospital, cesarean section, or minor transient risk factors like surgery with general anesthesia, being hospitalized, estrogen therapy, pregnancy, and leg injury, and then being confined out of hospital as well. But then there are also chronic persistent risk factors that aren't necessarily hereditary thrombophilias. Active cancer with or without chemotherapy. We know inflammatory bowel disease is a pretty significant risk. Autoimmune disorders, infections, and chronic immobility. So these are all chronic persistent risk factors. And as we'll see, the recommendations will differ. Now, if you have a transient risk factor, in general, short-term anticoagulation is the recommendation. And this is recommendation number 12 in the guidelines. But if you have a persistent risk factor, you may want to extend that anticoagulation. There are many different studies you could look at, and you can actually spend a lot of time pulling the original studies to look at the risk of incident and recurrence. But in the guidelines, they summarize doing systematic reviews and of randomized controlled trials and systematic reviews. And the estimate of annualized recurrence rates after provoked venous thrombosis was, for a pulmonary embolism, 1.89, and for a deep vein thrombosis, 2.31. So that is the consolidation analysis of all the studies that were available at the time of publication of the guidelines. They also looked at the major bleeding rates, pulling data from all these studies. And you can see the major bleeding rates defined by the ISTH criteria was about 2.1% per year. So you can see after a provoked deep vein thrombosis, the risk of recurrence is perhaps maybe the same or lower compared to the major bleeding rates. Now, if your patient is on warfarin anticoagulation and not managed very well, I would propose that the bleeding rate is going to be much higher. But the bleeding rates with the DOACs, apixaban, rivaroxaban, is much lower. The one good thing that these DOACs have done is they've really tightened up management of warfarin into protocolized approaches. So the bleeding rates with warfarin has come down over time. So that's the bottom line here is provoked deep vein thrombosis, 3 to 6 months of anticoagulation, and then you're done. Now, if you have a chronic persistent risk factor, you probably want to extend the anticoagulation. What about an unprovoked deep vein thrombosis? This is a very nice review by Dr. Roger from Canada. And I'd encourage you to pull this article to review this, where they'd really talk about unprovoked venous thrombosis and discuss a lot of things. There aren't many studies that look at recurrence rates after unprovoked deep vein thrombosis, so they're listed here. I'll be talking about Roger's study, which I thought was one of the better done ones. He had a lot of patients in his study, but the longest follow-up was Prandoni's study, where he showed that out to 8 years, about half the patients with unprovoked deep vein thrombosis have had a recurrence. So this provides you with a high-level view of the data, but perhaps it would be very useful for you when you're counseling a patient to know what the annual risk of recurrence is. So let's take a look at that. In Roger's study, which he published back in 2008, they looked at over 600 patients with an unprovoked first deep vein thrombosis who had been anticoagulated for 5 to 6 months. They excluded patients with a known thrombophilia. Now, they don't do thrombophilia testing up there, so sometimes patients did get tested. They were excluded. They also excluded patients with other indications for ongoing anticoagulation. At the time of publication of this study, the follow-up was about 3 years. The bottom line here is men were found to be in a high-risk subgroup. Women, however, could be stratified into a high and a low-risk subgroup. And this was based on a scoring system called the HER2. So evidence of post-phlebitic syndrome, a high D dimer, obesity, and older age. For men in this study, the annual risk of recurrence was 13.7%. Pause on that a little bit and think about that. 13 out of every 100 men with unprovoked DVT will have a recurrence each year if you stopped anticoagulation. You balance that against the risk of continuing anticoagulation, which is perhaps 2 to 3% per year. I think the balance shifts in favor of continuing anticoagulation. I am going to add some caveats here. This is a study done predominantly in the white population. Does this apply to the non-white population, to the African population, to the Asian population, to the Indian population? I don't know. I haven't seen any studies coming out of India or the rest of Asia, but perhaps it has to be done because it's expensive to continue anticoagulation as well. I use this website very frequently. It's called mdcalc.com, where a lot of these tools are online. So that's the website, and I've taken some screenshots that I'm going to show you here. So this screenshot shows you there's two different scoring systems on this website. One is called the DASH and one is the HER2 scoring system. Now the HER2 scoring system is really only meant for women with unprovoked venous thrombosis. So in the DASH scoring system, includes measurement of a D-dimer, but only measured 1 month after stopping anticoagulation, age, sex, and if the hormones was used. So if it's no, no, and no, you can see that the annual risk of recurrence based on this scoring system is about 2.4% per year, which balances out against the risk of hemorrhage with anticoagulation. So the recommendation is discontinue anticoagulation. Now, if you have a male patient with none of the rest parameters checked, the annual risk of recurrence goes up slightly. And this number is starkly different than what was shown in Rogers' study, because just being a male puts you at a risk of 13% annual risk of recurrence per year. But in this scoring system, in this study, it wasn't as high. However, if you were a male and above 50 and had a D-dimer that was elevated at the 1 month after stopping anticoagulation, your annual risk jumped to about 20% per year. So you can see using this decision tool can give you a rough idea of what the individual risk of recurrence is and balance that out against the risk of hemorrhage. Now, why this was so different, just being a male in this study was only 3.9%, but Rogers' study was so high, perhaps design methodology, whatever. So there's, as you know, any study that's done, it really depends on the design of the study. So this is a photograph of post-phlebitic syndrome, a patient with probably the worst kind of post-phlebitic syndrome. She has a venous ulcer. And looking at using the HER2 scoring system in Rogers' study, looking at the annual risk of recurrent venous thrombosis, high-risk women with 2 or higher score had about a 14% risk of recurrence per year. But if you have a score of 0 or 1, it's very low. So in this group of women, you can discontinue anticoagulation. So coming to the same MDCalc website, looking at the HER2 scoring system, if you selected no for all, your risk of recurrence was only 3%. Now, again, this is for women, not for men. Your risk of recurrence is 3% per year. So you probably could discontinue anticoagulation. But if you selected yes for everything, yes for post-thrombotic symptoms, high D-dimer, high BMI, age, the risk of recurrence goes up to 7.4% per year. So in women with a score of 2 or higher, the risk does go up and probably is higher than the risk of hemorrhage. And therefore, you would probably continue anticoagulation. Overall, what's the annualized risk of major bleeding? And this is where if you go into the original studies to look at the direct-acting anticoagulants versus vitamin K, you can see that the risk of hemorrhage with edoxaban, dabigatran, rivaroxaban, and apixaban, major hemorrhage, is pretty low. And in these clinical trials, warfarin was very, very carefully managed, and therefore the risk of hemorrhage with warfarin was equally low. So the point here is if you have a good, solid warfarin clinic that really carefully manages the patient's INR, and you need a compliant patient, because if you have a compliant patient on warfarin, there's not much you can do. I think the risk of hemorrhage balances out. Here's the take-home message. Men and women with a HER2 score of 2 or greater have a bleeding risk for ongoing anticoagulation that is lower than the risk of recurrent venous thrombosis with unprovoked venous thrombosis. However, provoked venous thrombosis and women with a score that's less than 2, the bleeding risk is equivalent, and therefore the decision to discontinue anticoagulation is reasonable. I have spent so far a lot of time on clinical predictors, provoked versus unprovoked. And that sort of tells you where sort of our societies are moving towards. They're not particularly spending a lot of time on the thrombophilias. My own practice, I direct the special coag lab. I'd love people to order the thrombophilia profiles, but I don't think it really affects management. My own personal practice, even though I run the lab, it's been many years since I've actually ordered a thrombophilia profile because it does not make a difference in management for the large majority of patients. Let's move to a case now of a 70-year-old. We've talked about incident venous thrombosis and the risk of recurrence so far. Let's talk about patients with recurrent venous thrombosis. I'm actually seeing some questions here. Let me just open them up. Can you see my screen as well with the questions, or I can read them out as well?
Yes, we can see.
Okay, so should asymptomatic offspring of patients with combined thrombophilia with history of venous thrombosis be screened? The first part of the question, I would say no, because for the asymptomatic patient, even though they have a parent with athrombophilia, the long-term risk of venous, and it might depend on what that thrombophilia is, so I'm going to qualify that. If the parent has protein C, protein S, or antithrombin deficiency, I think those are much more serious thrombophilias. Yes, they should be screened, because at least for antithrombin deficiency, patients with congenital antithrombin deficiency, about half of them have had their incident event by the time they turn 50. So at what earliest stage should you screen? I would say I would not screen when they're children, because pediatric population the reference ranges are not well established. So I would say you could probably wait till they get to 16, 17, 18, 19. But certainly before if it's a daughter you have and it's going to be prescribed oral contraceptives, certainly before that is prescribed, I would screen them. For 5-Leyden prothrombin, I strongly advise against screening. So you have a 30-year-old male, non-smoker, unprovoked superior mesenteric vein thrombosis with protein C heterozygous mutation on next-gen sequencing. Wife is now 2 months pregnant, no symptoms. Do we need to screen wife for protein C activity? The first part of the question, should you screen the wife? My initial reaction is perhaps not, unless the wife has a strong family history of venous thrombosis. Do we need to give lifelong anticoagulation to this patient, so the 30-year-old male non-smoker with unprovoked SMV thrombosis? I would say yes. Superior mesenteric vein thrombosis is serious. That could go on to a portal vein thrombosis, Chiari syndrome. The protein C was tested. I assume the protein C activity was tested and not just next-gen sequencing. But just the presentation with superior mesenteric vein thrombosis, I would perhaps be looking for other thrombophilias, PNH, myeloproliferative neoplasm, although he's pretty young, 30-year-old. I would be looking for those conditions. A word on protein C and gene testing. Many years ago, when I did my research with the investigator who was an expert in hemophilia B, we did a very nice analysis. We looked at large cohorts of patients with hemophilia B and found their mutations. And it was very clear that the mutations were located in very highly conserved regions of the factor IX gene. What do I mean then that? We aligned the factor IX gene with the factors, all the vitamin K dependent factor genes, and we even aligned them with going back to different species: monkey, birds, alligators, snakes, fish. I actually sequenced the fish gene as well. For factor IX, for hemophilia B, all those mutations were located in highly conserved domains. I did the similar analysis for protein C. So I looked into the protein C published database and I aligned it with the alignments that we had. There was no correlation. So we were very confused. What does a protein C gene mutation actually mean? I would think you would have to really prove that the mutation that you're finding is functionally relevant. The good news now is there are many, many good databases and analytic tools where you could do that. Nevertheless, practical management, the patient has had a very serious thrombosis in the superior mesenteric vein. Doesn't matter what the gene testing shows, that patient requires lifelong therapy. Now, there is one impact. It depends on what the patient is being treated with. If the patient truly has functional protein C deficiency and the patient is on warfarin, if you ever interrupt that warfarin for a procedure or surgery, whatever, it is very important to bridge that patient with heparin, because with congenital protein C deficiency, if you just resume warfarin alone without bridging parenteral anticoagulation, there's a high risk of warfarin skin necrosis. So there is some utility to knowing what the protein C functional activity is. Thank you for those questions.
So shall I ask a question now, Dr. Rajiv?
Sure, go ahead.
Yes. So I'm Dr. Karthik. So just want to ask a question. When do you order for thrombophilia testing apart from APLA workup in a bad obstetric history patient?
APLA, you mean antiphospholipid antibody syndrome?
No. When you order for thrombophilia, genetic thrombophilia testing in a bad obstetric history patient.
Okay. The American College of Obstetrics and Gynecology is sort of, apart from testing for antiphospholipid antibodies, they're kind of moving away from genetic thrombophilia testing. So they actually don't recommend that anymore. So if you look on their website, the guidelines, ACOG guidelines, you can see their updated recommendations. Dr. Seema Tyagi, you have a question?
Yes. We know about the acquired factors for prothrombotic disorders. Can you hear me?
Yes. Yeah.
Okay. But for genetic factors, they are expensive also as far as Indian scenario is concerned. So would you recommend, or are there any guidelines for the 1, 2, 3, 4 or as many that this combination is ideal to diagnose prothrombin disease or prothrombotic disorders, especially when other tests are negative? Others means acquired tests are negative.
I see. So you mean, is there a sequence?
Because what happens? What happens in our scenario? They advise all the tests, and it is difficult to choose 1 or 2 or 3, 4 tests.
Yeah.
They are not considering the cost pertaining to the patient.
Yeah. That's a really good question. It's very relevant. And even in our institution, if you're going to do testing, we recommend you do the full panel, because you can order one test, it'll be negative, and you assume there's no thrombophilia. But then what about the other conditions? But I would take it at a level, one step back and a higher level. And I ask myself the question, is it going to change your management? And if the patient that was just shared with the superior mesenteric vein thrombosis, for example, I would argue that apart from perhaps the antiphospholipid antibody syndromes, none of the other conditions would change management. Maybe the protein C if it's a low activity. So that's my approach. And in fact, the fellows that I work with nowadays, if I even talk about thrombophilia testing, they challenge me. How's it going to change your management?
Yes.
So once in a while, when I want to test, I back down. I say, well, you're right. It won't change management. There's one variable here that is very difficult to ignore. Many years ago, when we first introduced the Factor V Leiden test in our laboratory, I got a call from a patient directly into the laboratory to my phone number. I don't know how he got my phone number. And the first thing he tells me is, I want the Factor V Leiden test. I'm like, who are you? So apparently it was a patient that had been admitted to Mayo Clinic with a pulmonary embolism. Then he went home, and everybody in his community was telling him, his friends and family, you need the 5-Leiden test. So how do you resolve that issue of the patient's desire to know, or at least to exclude, is there a serious thrombophilia in my family? I don't think there's good guidelines to that, right?
Because similar situation happens with us when we say these tests are not required at the first go. You do acquired factors, you rule out acquired factors, you do lupus, you do blood, non-blood group, but they don't agree. They say prothrombotic factors or prothrombotic gene are the first one to be done, not considering the patient, not considering cost to the patient.
Cost. Yeah.
And patient can't say no because he or she thinks that these are the conditions where we need to diagnose, but actually we did not need to diagnose the condition.
Yeah.
So what is the resolution to this condition?
Right. So I think it's going to vary by patient, and I'm sure just like here in India, when you actually counsel a patient and you explain,
and prevalence is very low, especially factor V Leiden.
Yeah, I was going to add that's another variable. I mean, in the US, when we counsel, okay, what's the most common thrombophilia? 5-Leiden, prothrombin, and then the deficiencies. However, if you have a patient that's very young and develops an unprovoked thrombosis, and you kind of reverse that, I would probably be checking the protein C, protein S, and antithrombin first, because those are the ones that's going to make a difference in that young patient. Having said that, I think it was the United Kingdom group that published data on how badly labs perform on proficiency testing. So the same protein C sample sent to 200 labs, a normal sample, some of them are saying there's protein C deficiency. So that's another variable you have to consider. And so at least in the United Kingdom, they're very nihilistic. They said, if you got bad labs that are giving you bad results, why are you doing the testing? So there's that variable, and it gets much more complicated than that. Now, are there any studies from India that show a prevalence of one mutation over the other, or no?
No, but I know that factor V Leiden is very low. In fact, within 1 year, we found just 1 or 2 patients which are positive for factor V Leiden.
Yeah,
very low.
And when you tell a patient it's that low, do they still want to have the testing?
Some may patient want, some may not, because it's a matter of money. Some say you test everything, and some say no, you do whatever is relevant.
It's such an individualized situation, isn't it?
It's more a problem of resident doctors, because they don't want to leave anything untouched. They want to test everything and then want to start the treatment.
Yeah, I think many years ago, somebody had shown some data on your phase of your career and the number of tests you order. And when you're young, you're up there. But as you get old and experienced, it kind of goes down because you're more practical as you, maybe you're wiser, right? Okay, good questions. Thank you.
So more teaching and more awareness is required.
So you're touching on a very important point. And I'd like to say we have it perfect at Mayo Clinic. We don't. You can educate till you're blue in the face, but every year you have new residents, new fellows, and you have to do the same thing. So I think you need systems in place to be able to control the testing. And I can't say that we have a good system, because physicians in our institutions are ordering tests. The patient is on heparin or direct thrombin inhibitor, and they order the thrombophilia profile. Those results are going to be horrible because there's so much interference by the anticoagulants. So, we try. There is a publication where they tried to control testing for heparin-induced thrombocytopenia. That's an overordered test. And the system they set in place of electronic orders was you had to put in the 4T score before you order the test. Guess what? Everybody had an intermediate score.
Mm.
Nobody had a low score, because if it's a low score, you don't order the test. Did the patient really have an intermediate score? No, they just wanted the test. So you can set up electronic controls with electronic health systems, but people will find a way around it. All right, so we'll move on to.
Okay, Dr. Rajit. Thank
Yeah,
you.
sure. We'll move on to this next case. There's another question in the box. Okay, so this is a follow-up from the mesenteric vein thrombosis. So antiphospholipid, JAK2, PNH, negative, good, okay. So this is more of an idiopathic. The only other thing I can think of with a mesenteric vein thrombosis is if the patient has inflammatory bowel disease. You know, sometimes they're subclinical, but that may be the only other thing I can think of. And if you've excluded all of that, I think you're left with an unprovoked idiopathic mesenteric vein thrombosis. So here's a patient that I saw a few years ago. All of these events I'm going to describe happened at his local institution before he was referred to Mayo. His first event, now he's 70 when he had his first event. I'm sorry, when I saw him, he was 70. So a couple of years before that, left lower extremity deep vein thrombosis, completely unprovoked. So he was managed with heparin and warfarin. 2 months later, he had his first recurrent deep vein thrombosis. Same anatomical distribution. So when you see this, when you see a recurrent deep vein thrombosis, there's a few things that go through mind. Patient was on warfarin. What was the INR? Was it therapeutic or not? And quite often when I'm seeing referrals for refractory thrombosis despite warfarin, the large majority of the time, it's because they had subtherapeutic INRs. Never forget anatomic abnormalities. So it's perhaps rare, but May-Thurner syndrome, which is compression of the iliac vein by the iliac artery in the left side predominantly, can cause a mechanical obstruction and recurrent left lower extremity deep vein thrombosis. And once in a while, when you have an inexperienced radiologist, they just misread the Doppler because there may be chronic thrombus. Only 20 to 30% of patients who have an incident DVT have complete clearing of the thrombus. Large majority of patients are left with a chronic thrombus, and that can be misread as an acute thrombus. So these are the things to keep in mind. This is an example of a patient I saw with, this is a different patient. He had about 8 recurrent deep vein thrombosis in his left lower extremity. And he had a lot of pain in his left leg, and his recurrent DVT was despite therapeutic warfarin. He was switched to enoxaparin. He was switched to fondaparinux. He was even put on a combination of enoxaparin, warfarin, and aspirin, and he kept getting recurrences. And so when I saw him, I did a CT angiogram, and you can see extensive collaterals. And up here in the iliac, up here, there was a compression of the iliac vein. And basically, he had a lot of collaterals. What he had was May-Thurner syndrome, for which you do need to put in a stent. So when you're suspecting May-Thurner syndrome, it's always better to consult with an interventional radiologist, get the appropriate testing, because a stent results in significant relief. So we ended up putting a stent in this patient. Okay, so here he is, coming back to our case. In his case, in his first recurrence, it was due to a subtherapeutic INR. Okay, so they get him back on enoxaparin and then transition to warfarin, and he goes 2 years, very well maintained INRs, and then he has a second recurrence. In this instance, he had to undergo inguinal hernia repair, so he interrupted his warfarin. And a week after that, even though he was back on warfarin, a week later, he developed a IVC thrombus, iliac vein thrombosis, and a pulmonary embolism. And what's worrisome is that his INR at the time of this event was supratherapeutic. So this is a bona fide recurrence, but I suspect because of the interruption, only for a week. It's a little worrisome as to what's going on here. Clearly, this patient has some sort of thrombophilia going on here. Anyway, they got him back on enoxaparin, transitioned back to warfarin. 6 months later, he has a superior mesenteric vein, portal vein, and a splenic vein thrombosis. At that time, his INR was about the same, 4.5. So here's a gentleman with 3 recurrences. 1 was subtherapeutic INR, 2 were therapeutic INRs. There's something going on here. Anyway, again, back then they didn't have the DOAC, so all they could do was put him on enoxaparin for a month or 2 and then get him back on warfarin. And about a year later, he develops hematuria, has a very extensive workup, and he was found to have a renal mass. And his physicians thought, okay, now they have an explanation. This could be the reason why he's having all these recurrences, despite therapeutic anticoagulation. So they did a nephrectomy. I mean, fortunately, it was not a cancer. Unfortunately, what they saw was a hematoma. And so they really did not have an explanation for why he kept getting these recurrences. And that's when he was referred to Mayo Clinic. So when I saw him, he brought all his records, and I documented his INRs. That's the first thing that I do. I get very obsessive with the INRs, and sometimes it takes me weeks, sometimes it takes me months to get the INR records, but I stay on top of it. Here's what was found on his records. At the time of his first recurrence, platelet count was 670,000. Second recurrence, 897,000. Third recurrence, 701,000. And in between these recurrences, his platelet count always was above 500,000 to 600,000. I strongly suspected this guy had a myeloproliferative neoplasm. And so I proceeded with the bone marrow biopsy, and what he had was a chronic myeloproliferative disorder. Now, back then, we didn't have the JAK2 mutation testing, but morphologically, he clearly had a hypercellular marrow with features consistent with myeloproliferative neoplasm. And so here was the diagnosis. He had recurrent thrombosis due to an MPN. This is a review article that Dr. Ayu Teferi, who's presented here before, published in 2021, updated. And this article covers very well the risk of thrombosis. And we put the patient that I just described, put him on hydroxyurea in addition to continuing warfarin. Again, we didn't have DOACs back then. We controlled his platelet counts. And as far as I know, I haven't heard back from him, but I don't think he's had any recurrent venous thromboembolism. So this is an acquired thrombophilia to keep in mind, myeloproliferative neoplasms. Nowadays, it's easier. You can do peripheral blood JAK2 mutation analysis, calreticulin testing as a screen. But in the end, I think you still have to do bone marrow biopsies. And the treatment is reasonably gratifying because you can either give them hydrea for polycythemia vera, you can give them hydrea and therapeutic phlebotomy. And then you have the new JAK2 inhibitors that are out there that may be useful in reducing the risk of thrombosis. Just a mention of this group of individuals with thrombocytosis. Some patients with thrombocytosis develop an acquired von Willebrand syndrome. So it's very important to do a good history and not assume that the platelet count puts the patient alone puts the patient at high risk for thrombosis, because if they have an acquired von Willebrand syndrome, putting them on aspirin might put them at risk for bleeding. So it's important to exclude that entity prior to prescribing.
Sir, I have a question, sir. I have a question, yeah. Dr. Karthik. So do you always rule out acquired von Willebrand disease before starting aspirin for any MPN patients, sir?
I think you go with the history. And if the patient has even a minor bleeding history, bruising, I do. I have to admit, I don't know if Dr. Teferi routinely checks. I believe the guidelines do suggest you should think about it and do test for it. Okay. And it might, and the levels of von Willebrand factor may be in the reference range. They may be in the normal range, but if you do the multimer analysis, there's a slight loss of the high molecular weight multimers. and the activity is slightly disproportionately reduced compared to the antigen. So those are the subtle signs that may lead you to making the diagnosis.
Okay. So because in India, it's a common practice that whenever an MPN patient, especially ET patients come, we directly start them on thromboprophylaxis with aspirin. So maybe Indian people, maybe the panelists in this group, hemato-oncologists, how they can tell how frequently they encounter this problem without testing, or do they prefer testing? Maybe
I think the way the guidelines have moved is my understanding is that the platelet count itself does not predict risk for thrombosis, and you risk stratify them. So if you pull up this article, Dr. Teferi and Barboui do a good job in providing the high level risk stratification guidelines. I do have a slide on that, and at the end of my talk, I can pull that up.
Right. So, and one more question. In the patients in which you are referring, the platelet counts were always high. Yeah, but it's always around 8 lakh, 5 lakhs. But the patient, whenever he was, but he was always on anticoagulants. Maybe the antiplatelet agents would have helped him, maybe.
Potentially, but I think in this situation, his prothrombotic condition was so serious that even now again, if you look at the circumstances also, with the first recurrence he was subtherapeutic, the second recurrence he had interrupted his warfarin, the third recurrence his INRs were completely therapeutic. So I think that in this patient, whatever clone he has was quite seriously thrombotic, and that led to his events.
Yeah, even with the other anticoagulation, he would have developed like that.
Yeah, probably. I think in this situation, he was old. I think that the high risk are those that smoke, are quote unquote old, and have a high platelet count. For those patients for prophylaxis, I think they do recommend aspirin.
Right.
But for the younger patient who doesn't smoke, does not have cardiovascular disease, we don't even give aspirin anymore.
Right. Thank you, sir.
I have some Q&As in here. So here's a question on a patient with Budd-Chiari syndrome with a JAK2 mutation at low variant allele frequency. Do we label them with a polycythemia with a normal? I think this disease entity where you find a low allele frequency of JAK2 and they've had a clinical thrombotic event, I think that's going to end up being a new disease entity, is my own view. Should you label them as polycythemia, even with a normal CBC and normal bone marrow exam? Perhaps not, but is this an incidental finding? Maybe in 5-10 years, they will get erythrocytosis. The fact that they've had Budd-Chiari, I think they need lifelong anticoagulation. Right now, I think warfarin is still the standard approach. At least I'm not aware if the DOACs have had much experience in this situation. So what are the common interferences that you come across thrombophilia workup when they're already on DOACs? Very good question, and we're seeing a lot of that. The lupus anticoagulant testing, based on the dilute Russell Viper venom time, you get prolongation of the screen and inhibition on mixing study, and yet the phospholipid step may be either negative or indeterminate. So that's one interference. And then if you're measuring antithrombin activity with an anti-10A based assay, the DOACs, so basically the apixaban and rivaroxaban, will falsely raise the antithrombin activity level and normalize it. But if you have an anti-2 based assay, Pradaxa or dabigatran will falsely normalize it. So there's two categories of antithrombin assays. One's based on factor 10, one's based on factor 2. And so those interfere with the assay. Apart from that, the chromogenic assays are not interfered with, and of course the ELISA assays are not interfered with. How do we investigate if a patient has high homocysteine with thrombotic presentation? In our setup, severe megaloblastic anemia is common. I'm not sure I understand the context of this question. So if you have a thrombosis and a high homocysteine, that is, there is an association of thrombosis with homocystinemia. One of the challenges with that is, I think it was the Swedish that showed that treating the high homocysteine, so giving them folic acid or B12 or replacing any multivitamins to bring down the homocysteine level, did not seem to reduce the risk of recurrent thrombosis. We still test for it. We still put the patients on the vitamins. I'm not sure it makes a difference. With severe megaloblastic anemia and high homocysteine, you do worry about B12 deficiency, of course, folate deficiency as well. So it's important to test for those situations. Okay, good questions. Thank you. And what we can do is move on to some selected thrombophilias, just to complete the loop on thrombophilia testing. Let's look at factor V Leiden. Again, this is common in the white population. So V Leiden was described in 1996. In 1997, the Italians came up with their cohort of patients and looking at risk of recurrence with versus without the mutation. This is a pretty high risk of recurrence. So up to 40% had a recurrence within 2 to 3 years of follow-up compared to those without a mutation. One could argue that even those without a mutation had a pretty high risk of recurrence. So what did we do? We didn't have the DOACs back then. We started leaving our patients on long-term warfarin. I'm not sure we did them any favors. A couple of years later, the Dutch came out with their data showing that non-carriers had no higher risk of the heterozygote carriers had no higher risk of recurrence compared to non-carriers. And so there's only 2 studies. One study that I showed you, and there's another one that shows there is a higher risk of recurrence with heterozygotes, but most other studies done show there's no difference. Homozygotes, though, do appear to have a higher risk of recurrent venous thrombosis. So perhaps, depending on the situation, if you've tested for V Leiden and you find a homozygote, you perhaps want to treat them with long-term anticoagulation. I'll tell you, I've seen patients who are homozygotes and they're in their 70s. They've never had a deep vein thrombosis. So I think it's very individualized. The bottom line here is that heterozygote V Leiden prothrombin alone does not justify long-term anticoagulation. You really need to take the clinical circumstance into context and categorize the patient into a provoked versus unprovoked venous thrombosis. And we covered that in the beginning of my presentation and talked about the individualized risks of recurrences. So V Leiden prothrombin are really not strong risk factors for venous thrombosis. But what about the deficiencies of the anticoagulants, protein C, protein S, and antithrombin? They are very rare. So in this study, I think this is from the Dutch, very small number of patients in each cohort. But this row provides the annualized risk of recurrence that varies from 6 to 10% per year. That is a pretty high annualized risk of recurrence when you balance that against the risk of hemorrhage with ongoing anticoagulation. And if you follow these patients over 15 years, you can see up to 60 to 70% of them have had a recurrence. So, in the beginning, I said you really shouldn't be testing. And yet I'm showing you this data that, boy, if you have protein CS deficiency, there's a pretty high risk of recurrence. So I probably mentioned that the biases creep in here. And so if I have a young patient, a young white patient, which is the most population that I see, with venous thrombosis and a family history of venous thrombosis, I probably would look for one of these deficiencies, especially if it's a female patient. Why is that? Because if you have a deficiency of one of these proteins and they're going to be prescribed oral contraceptives, that does put them at a higher risk of venous thrombosis and managing their pregnancy. So with antithrombin deficiency, it's particularly gratifying to make the diagnosis. As I mentioned, I personally would give them prophylaxis, antepartum and postpartum. But in the peripartum period, when you stop the prophylaxis, you can replace antithrombin concentrate to get them through the pregnancy and further lower the risk of venous thrombosis during the labor and delivery period when you really can't use anticoagulation. We don't really have protein C concentrates, but again, warfarin skin necrosis is an issue with these two deficiency states. If you have a combined thrombophilia, so only one defect or one other defect or more than two defects, you can see the annual recurrent rates does go up and the relative risk does go up. And this again, exemplifies the concept that venous thrombosis is multifactorial and you can have more than one risk factor, congenital risk factor for venous thromboembolism. This slide summarizes the odds ratio, the relative risk of recurrent venous thrombosis for each condition. So 5-Leiden prothrombin is pretty weak. You can see the odds ratios are pretty small and the confidence intervals cross unity. But the deficiency states are high risk, antiphospholipid antibody are high risk. I didn't show a case of antiphospholipid antibody syndrome, but I will say that that is one of the tests that I routinely do in patients with venous thrombosis, because it's been shown that if you have a triple positive antiphospholipid antibody, so lupus anticoagulant, anticardiolipin antibody, and anti-beta-2 glycoprotein 1 antibody, that group of patients, if DOACs are inferior compared to warfarin for management of deep vein thrombosis. And if you have a persistent antiphospholipid antibody, long-term anticoagulation is warranted. So I'm going to conclude now and just touch on a few things we talked about. When you have a patient with venous thrombosis, both the short and long-term management of venous thrombosis really varies with clinical presentation. So you really should be looking at provoked versus unprovoked. I think the role of thrombophilia testing is controversial because in my own view, it rarely affects management. And I think our society guidelines are also considering the same thing because the latest guidelines don't really address thrombophilias. When to test, what do you do with the results? I would say that I didn't touch on it again. I shared one case of a myeloproliferative neoplasm, but if you have a patient with an unprovoked deep vein thrombosis, it used to be patients would go on extensive testing looking for cancer, but randomized trials have shown that extensive testing is not indicated because it does not prolong survival. The yield is low. So the approach to cancer testing, I can summarize by saying age-appropriate cancer screening is appropriate, symptom-based and physical finding-based case detection is appropriate. So that's the high-level approach to cancer and venous thrombosis. Well, I want to thank you for your attention and engagement and good questions that you had. I'll go ahead and stop sharing my screen and be happy to take additional questions. Dr. Bowman, you have a question? Dr. Karthik?
Yeah, can you hear me, sir?
Yes, yeah.
Yes, sir. So, very nice talk and very educative talk. Thanks for that. So I just want to know, so how do you approach a case presenting with arterial thrombosis? How you investigate arterial thrombosis?
That's a whole different ball game, isn't it? and so you could classify that by stroke, myocardial infarction, or peripheral arterial embolism, right? Yeah. I think uniformly, anyone with arterial thrombosis deserves testing for antiphospholipid antibodies. Our genetic hereditary thrombophilias that I just talked about really don't seem to be significant risk factors for arterial thrombosis at all. So that's the diagnostic part. So my approach to patients is what's the diagnostics and what's the therapeutics? Therapeutic-wise, for any peripheral arterial thrombosis, I would never stop anticoagulation. So would I necessarily do extensive testing apart from the antiphospholipid antibody? I wouldn't. Now, if you have a stroke, it's a whole different ballgame. You're looking for a source of the embolism. You're looking for vascular causes. And I will also add that, and this happens particularly with renal arterial embolism, patients present with an infarct, and it is assumed there's an embolic infarct, but many a time it's actually a vascular dissection. So think anatomic, think systemic. And you know, you really need a skilled interventional radiologist to make that diagnosis. So I work very closely with our radiologists. Yeah. Dr. Ruchi?
Thank you, sir, for an excellent presentation. Am I audible, sir?
Yes.
Yeah, sir, I would just like to know that we do APC resistance test for factor V latent mutation. So can it differentiate between homozygotes and heterozygotes? Is there a cutoff?
Your lab would have to validate that. So in short, if you validated, the APC resistance ratio is much lower for homozygotes than heterozygotes. But in my opinion, there's a big overlap as well. So I think it's not a very accurate test for that.
So genetic testing becomes mandatory then, because if we cannot differentiate heterozygotes and homozygotes, so we cannot say that APC resistance rules out factor V latent mutations, sir?
Well, if the APC resistance ratio is normal,
okay,
the likelihood of 5 latent carrier is almost zero. Yeah. The only thing you can't differentiate if you have a low ratio is homozygotes versus heterozygotes. So the scenarios are, if you're screening, the APC resistance is definitely a more cost-effective test. But if you already have a family member who is known to be a carrier and you're seeing another family member and they want to know if they're a carrier, you might as well go to the DNA test, right? Because you already have about a 50% likelihood that that patient may be a carrier because of a first-degree relative.
But can APC resistance be positive in other conditions as well, other than factor V latent?
Right. So there are some conditions. So in some cases of antiphospholipid antibody syndromes, you can get an acquired APC resistance. During pregnancy, you can get an acquired APC resistance. But the mechanism for that, for the pregnancy-related one, is that the factor VIII levels go so high, and that can induce an acquired APC resistance. Those are the two really known conditions. There is one sort of an acquired condition. When you do APC resistance testing, you're testing for plasma proteins that are produced by the liver. So if the patient has had a liver transplant, you know, there may be a discrepancy between what's in the plasma and what's in the leukocyte genomic DNA, right? So it's very important to get that history.
Okay, thank you so much, sir.
Okay, Dr. Jasmita?
Good evening, sir. Excellent presentation. My question is regarding the D-dimer levels. So most of the articles, they reference a particular kind of D-dimer. For example, the HER2 score that you talked about showed a VIDAS D-dimer cutoff, while the scores that are applied in the calculators are sort of generic, and so that doesn't say that it has to be with the specific D-dimer assay. So what relevance of that D-dimer assay do you place in your lab when you follow up these patients?
Yeah, you know, that's a really good question. So the same group, Roger's group that showed the VIDAS D-dimer, they did a follow-up study looking at a variety of other D-dimers, and they showed that only the VIDAS was predictive. So you're absolutely right. Can you extrapolate what they're saying to your laboratory? Maybe, maybe not. I mean, the way I use D-dimer is if it's positive or negative, you know, and that's it, despite what the VIDAS studies showed. I think you're looking at thrombin generation and clot formation, and the D-dimer is pretty sensitive for that. We use the IL-based, it's called the high sensitive D-dimer, and it's very sensitive to D-dimer. So I think it's reasonably accurate.
So the cutoff for your assay would somewhere be around 234 as given in the kit insert, or would you take a cutoff of 500 to look for patients who would require long-term anticoagulation?
In our lab, it's 500. Yeah.
Thank you, sir.
Yeah, Dr. Jasmina? You're still on mute.
Yes, can you hear me now?
Yes.
Thank you, Dr. Pruthi. That was a wonderful lecture. And I work in the lab, so my questions are a little bit lab-based. The first one is that we get a lot of requests to do thrombophilia testing in patients with Budd-Chiari syndrome because of the guidelines saying that we must test for patients who have thrombosis in unusual sites. But most of them have a deranged liver function. So most of the protein C and S and antithrombin values come to be abnormal. So I really don't know how good it is to test for thrombophilia in these settings, but I'm told that it is required by their guidelines, to look for these deficiencies. So what do you people do?
Yeah, are these the GI guidelines, gastroenterology guidelines?
Yes, yes.
Okay. Yeah, I share your sentiment. Those are very misguided guidelines. It's the same with the neurology guidelines. They say that you should do comprehensive coagulation testing for patients with stroke, but they don't define that. and I'm with you. And even our practitioners here, there'll be a patient with advanced cirrhosis on a liver transplant list, and then I get this thrombophilia profile in my lab. It's like, oh my gosh, no, it's going to be deranged. I hear you. Once somebody called me and said, should I do the testing? And I challenged him and asked him, so what will you do with the information? It was a patient who had a portal vein thrombosis and advanced cirrhosis. And the reaction I got was surprising. He said, oh, wouldn't you want to know? I said, but that's okay. What will you do with the information? Are you not going to anticoagulate the portal vein thrombosis? He said, no, of course I'm going to anticoagulate him. So the good news is that particular practitioner said, oh, I shouldn't be testing. I said, yeah, you're right. My lab loses business. I don't care. The patient's not paying for it. Right? So I would say for the scenario you're describing, the Budd-Chiari, the most useful test would be antiphospholipid, JAK2, looking for myeloproliferative neoplasm. Those are the practical ones where you may be able to do something about. All the other conditions the lab assays are going to be not very useful, or it's not going to change management. We sign out, now, not just the Mayo practice, but we have a reference lab practice from across the country. Every month, we're signing out 1,200 thrombophilia panels. That's a lot, a large majority are normal. That's a lot of wasted money, but that seems to be the defensive medicine practice, isn't it? And there may be an element of that is the patient says, just like, I think was described, the patient wants the testing. What do you do?
I get that. So am I allowed another question here?
Sure. Yeah.
Yes. What do we do with borderline values, which are borderline on repeat testing? I can't for sure say that these are heterozygous because we don't do DNA testing for most of these. They are not done upfront ever for protein C, protein S, and antithrombin 3. But if I'm just sitting on the lower limit of, the lower cutoff, what do we do? On a repeat test, it's again borderline.
Yeah. So specifically, for instance, protein C, let's say.
Yes. Okay. Yes.
So this is just of all the patients that I've seen with congenital deficiency, it's never borderline. It's always truly deficient, 20%, 30% of normal. So the borderline ones, even if they're slightly below the reference range, I just say of uncertain significance. Same with antithrombin, same with protein S. Protein S activity assays are particularly not very well standardized. So that's a huge limitation with that assay. So we offer the antigen first, and if it's abnormal, we might do the activity. But if the antigen is low, you already know the patient has a congenital deficiency, right? If they're not on warfarin, not pregnant, all those acquired conditions come into mind.
Thank you for that. And one last question. So we do get some samples from the pediatric neurology unit for their stroke patients, because I think it's part of their recommendation too, to screen for deficiencies. And children are of different ages, and we know that the values change over time. So if we get a deficient value today, what should be our recommendation? When should the child be called for a repeat test? Because if I say send the child at close to puberty, when I think protein C will be normal, he gets anticoagulation for that whole duration, or doesn't he? What should happen? What does everybody do?
So your lab presumably has adult reference ranges, right?
Yes, we do.
Yeah,
and we look at literature for the pediatric reference ranges, because you can never validate your own normal population for pediatrics.
You know, we actually are in the same boat, even today, 2022. We don't have our own pediatric values. We look at the literature. I mean, the good news is 3 years ago, we started our effort at pediatric reference range studies. So we actually are far along. We've collected so many samples. The only way we could do that was offering money. So, you know, you can imagine a child calling a parent and saying, you know, we have a normal value program within our institution, and we offered normal donors money to come and give a sample of blood periodically. Nobody did that for pediatrics. We were our coag lab was the first one to do it. And it was amazing at this, you know, kids want to have their iPhones, they want their games, so the parents say, oh, $50, hey, yeah, let's go. We're gonna poke you, you'll get a video game. Yes, mom, I'll do it. Now, I'm not sure I'd do that to a 1-year-old or a 2-year-old, but that's one incentive. It's not coercion, it's an incentive, and it's for the good. Our IRB approved it and all that stuff. To answer specifically your question, you're stuck with that patient who's got the low level. But tell me, when you look at the published reference range, is it within reference range for the pediatric group or not?
Yes, it is within.
Yeah, I at least my own practice is I come out and say it. This is within reference range for age, and leave it at that.
Okay.
Yeah.
Thank you for these answers.
Dr. Giri?
Hi, sir. Thank you for the presentation. It was very nice. I just have one basic question. When you say thrombophilia panel, what all is actually included in that? Is it just like factor 5 prothrombin gene and antithrombin and protein C, protein S, or along with that you include factor 8, homocysteine, and you also said like dysfibrinogenemia, all that is included, or how do you test actually?
Yeah, that's a good question. So our panel includes APC resistance, and we control who gets the 5-Liden. So if the APC resistance is normal, we don't do the 5-Liden. It includes prothrombin gene mutation. It includes the anticoagulant proteins, CS and antithrombin.
Okay.
Then we screen for dysfibrinogenemias with the thrombin time.
Okay, all patients, sir?
Yep, all patients. It's a part of the panel. And then we also do a fibrinogen level as well. So we do the thrombin time and the Klaus fibrinogen. That's really the basic panel. Let's see, I don't think, lupus anticoagulant. So that we don't do factor 8. The difficulty with factor 8, if you look at the data on that, it's mainly data in patients who have had an incident event, and then at a time that's remote from the incident event, you do a factor 8 level. And if it's still elevated, that predicts for recurrence. And the problem is, you don't know when, so because of our reference lab practice, we have no clinical information on the patient. So we don't know when that sample was collected. So we decided not to do it. And there are clinicians who are a little more knowledgeable and well-informed of the literature. They order the 8 separately, and that's fine. You know, we let them do it. We don't do homocysteine. We've stopped recommending homocysteine. We used to recommend, because we had the coag lab. Homocysteines are done in a different laboratory. We used to recommend, if not done, do the homocysteine level. We stopped recommending that, because when the Swedish came out with their outcomes-based, analysis where lowering homocysteine didn't seem to affect risk of recurrence, we just stopped recommending it. And then the ELISA assays for the antiphospholipid antibodies, the beta-2-glycoprotein 1, cardiolipin, again, that's done in a separate lab. So we simply recommend it in our note. If you haven't done this, consider doing it. That's the panel. We used to have plasminogen as our panel, and years ago we got rid of it because it's not a thrombophilia.
Okay. And one more thing, if a patient with history of recurrent thrombosis, we have done APLA workup and inherited thrombophilia workup, everything is negative, then is there any further testing for these rare inherited thrombophilias, or we stop there? Like,
yeah,
any role for further testing? Like you said, idiopathic thrombophilia, you labeled that patient like that. Do we label any patient like that, or do we have to test further? Does it have really any implication?
So the sequence of approach is, if you have an unprovoked venous thrombosis and it's recurrent, and then if you want to do the testing, I think the sequence can vary. I would say, depending on the age, screening for cancer is very important, right? So you do that. And then if you're going to do the thrombophilia panel, if that's negative, and then depending on the anatomical location of the thrombus, you might be looking for JAK2, you might be looking for PNH, things like that. So I think it's so individualized, but if everything's negative, we stop. We just say unprovoked, stay on lifelong anticoagulation. Yeah.
Thank you.
Okay. Yeah. Dr. Karthik? You're still on mute, sorry.
Yeah, sorry, I have two questions. So do you have any role? Do you think there is any role for testing for this anti-annexin and anti-phosphorylserine antibodies in a patient with bad obstetric history and traditional blood testing is negative with beta-2-glycoprotein 1 with bad obstetric history?
Yeah, so the anti-phosphatidylserine antibody testing is coming, more into prominence. One of the questions, though, is, at least the last talk I heard by an expert on this topic was, does that add anything more to the beta-2-glycoprotein 1 antibodies? I think there's still controversy. Now, the immunology lab at Mayo does offer that test. I honestly don't know if our obstetricians are ordering it or not.
Yeah, because in some private, like I'm in Chennai, because some of the private hospitals, as a part of the extended panel, they get these things tested. And we've seen many patients who are having bad obstetric history, who are negative for this beta-2-glycoprotein 1 and anti-cardiolipin. Some of those patients turn anti-annexin 1 positive. So it is having an implication for them while because they are having poor distressed patients. Therefore, they are wanting some answers to the patient. So maybe it will be coming in the guidelines. What's your opinion, sir?
Yeah, I have to admit ignorance on that aspect, because the anti-annexin 1 is not so much of a thrombophilia. I'd have to defer to my maternal fetal medicine colleagues. We don't have that assay in Mayo, so if they're ordering it, it's being sent out. I'm not sure what they do with that assay.
Right, sir. Yeah. And then my second question is, like, do we follow the corona scoring system for thrombophilia risk assessment in your solid tumor patients?
Yeah, so our oncology group, so oncology is a separate department than hematology. They are using that to risk stratify patients as an outpatient for thromboprophylaxis.
Right.
I'm on the guideline development group for within Mayo. I haven't had. We're working on implementing that into our systems, because with our electronic health record, if our health record can give the practitioner that information, they may be able to use that for anticoagulation prophylaxis.
Right.
I have to say it's not widely implemented yet.
Yeah, maybe because this scoring system is mostly useful for the solid tumors, because the scoring system itself, hematology becomes less useful score for doing the scoring, right? So do you have anything which will be more helpful for the hematology patients, like for pediatric leukemia patients or leukemia patients who are on asparaginase? So do you recommend any scoring system to be followed?
I'm not aware of any scoring systems for those diseases, but our practice in Mayo for the L-asparaginase patients is we routinely replace antithrombin, because the risk of thrombosis is very high.
Okay. Because I heard some studies like doing this antithrombin assay is not that useful in pediatric population. So you are doing that routinely. So antithrombin 3 assay, you are doing it, right?
So what we do is again, I don't think, at least in the adult population, L-asparaginase is not used that often anymore. But when you still use it in their protocols, we monitor antithrombin and fibrinogen, both. Now, what happens is both go down. So you could argue that the two balance each other out, right? You have hypofibrinogenemia, low antithrombin. But in our adult population, and I'm more familiar with our adult population, the incidence of venous thrombosis was 30 to 40%. And now you're struggling with a thrombocytopenic patient with a thrombosis. How do you anticoagulate? With antithrombin replacement, routine antithrombin replacement, so we measure it once or twice a week. We replace it, and we don't necessarily target a normal level. We get them up above 70-ish, which isn't quite normal. We have markedly reduced the incidence of venous thrombosis. I don't know if my leukemia colleagues are publishing the data, or I think since the adult population, we don't even use L-asparaginase much anymore. There's probably not much data to publish. The last what we discussed this, I remember the discussion with the pediatricians. I think the incidence of thrombosis was much lower, and maybe do you work with the pediatric?
Yes, sir.
Yeah.
Yes, sir.
I think the incidence is much lower. Am I right with that?
Yes. Yes,
Yeah.
sir. Because here also, because when I asked my pediatric hemato-oncologist, he told whether we should go for devising any risk assessment system for these patients. He told it's not required because our frequency is very low.
Yeah, so that's the key. The younger patients and the population prevalence of disease is much lower. So do you need to be doing all these extra things to reduce even lower an event that's much less frequent anyway? And then that's when you might be introducing cost and perhaps other risks. So I think the pediatric population is a whole different discussion. Yeah.
Thank you, sir.
Okay, Dr. Jasmeeta?
So, sir, as you rightly mentioned that you have a reference lab and you don't get history on the requisition forms many a times. So do you also adopt a practice where you would do a prothrombin time INR for all your samples before you start testing for protein C, protein S? And with the DOACs coming up, would you also do maybe a APTT? You do a thrombin time as a part of your panel, but PT and APTT before you proceed for the workup.
Absolutely. I should have mentioned PT APTT is a routine part of our thrombophilia panel as well. And then so the goal of the PT, if it's prolonged, you do a mixing study. You want to know if the patient is on warfarin, so the vitamin K factors may be done. APTT thrombin time to look for heparin and direct thrombin inhibitor. So yes, we do routinely do part of that.
So for your lupus anticoagulant tests, there is a difference in the guidelines. Most of the guidelines say that up to an INR of 1.5, you can still proceed with the testing with mixing. So many a times, most of these patients actually, when they are being anticoagulated, the INR that is going to be targeted would be above 1.5, and you would have patients whose INR is, say, 2.8. Would you proceed with lupus testing for them, considering the fact that with the DRVVT mixing, as in the DRVVT screen and confirm done with the mix, would be replacing the efficient factors? Would you do you do that routinely? Because that is a challenge that I have faced, at least because my clinical colleagues may be very reluctant in stopping anticoagulation for these antiphospholipid antibody syndrome patients, for the retest part of it.
Yeah, that's a really good question. Because of our high volume complex workflow, we do a lot of algorithm testing. If the PT is prolonged, we don't look at the result and then decide on a mixing study. We've programmed that into the instrument. If it's a lupus anticoagulant panel, it's all programmed. We just put the sample on. Everything is done based on programming. So we don't stop testing if the INR is 4.5, for instance. The weakness with that system, the programming it is, if you have an INR of 3 or 4, the DRVVT can be falsely positive. That's been shown. And so we have to interpret, we always interpret our results. We don't just send out the result. We interpret it, and then we caution the provider saying, this could be falsely positive because of anticoagulation therapy or liver disease or DOAC or something like that. I don't know that there's a good solution to that because of we do about 50,000 lupus anticoagulant tests a year. So and it's all automated, so it's be very hard to sort it out. The good news is 95% are normal, so they just go out automatically. We don't even look at the results. It goes out based on some calculations. If it's important, what I tell practitioners is it's okay to stop the warfarin, put the patient on enoxaparin, a low molecular heparin, for 3 to 5 days, interrupt the enoxaparin for 24 hours, collect your sample, get them right back on enoxaparin, if it's important to know. If it doesn't affect your management, it's okay, don't do the testing. Now, if a patient is at an arterial thrombosis, I'd be nervous stopping any anticoagulation, right? But it's important to know if there's a lupus anticoagulant. So that's when we kind of work it out, we negotiate, and we kind of, and I'm talking just about our Mayo practice. So we have the patient, we know the data, and we actually do the consult as well. Yeah.
Sir, if your arterial thrombosis patient says triple positive, would you do the 12 weeks later part of testing, retesting for confirmation, or would you consider that he has such a high rate of recurrence that you would forego repeat testing?
Yeah, we actually do encourage repeat testing if it is possible. The reality is, we've had two different colleagues look at our data, Mayo data, to see how often practitioners actually repeat the testing. One of the complexities of our practice is our patients come from so far away. They come here once and they may never come back again. So the percent of patients that actually have a 12-week repeat is very low, less than 5%. And so we're stuck with that situation where you've had a serious thrombotic event. It might make a difference in your management, but if they're already on warfarin, now if they're on a DOAC, then I would strongly say you really need to test, because if it's triple positive, you need to be on warfarin. Yeah.
One last question about lupus again. So we know that strong lupus anticoagulant may be masked when we are testing for TRBVT, even with the 1 and 2 mix, if you're doing it. So what prompts you to make serial dilutions of a patient sample to test for a strong L? Or do you do that in your practice?
For lupus anticoagulant specifically?
For a very strong lupus anticoagulant.
We don't really make dilutions. If the DRBVT is positive, it's positive.
If the DRBVT was negative, say, if the ratio comes out, the normalized ratio for screen to confirm comes out to say 1.1, and the patient has had a strong history, should we consider making dilutions in specific conditions, or can we just report the results out straight away?
So just to clarify, you do the DRVT screen, mix, and confirm, correct? So those are the 3 steps.
Those are the steps.
Okay. And so the scenario you're describing is you have a prolonged ratio with the screen, but the mix corrects.
So I'm describing a situation where the screen time is just marginally prolonged. The screen ratio is say about 1.2, 1.3, and the confirm ratio also comes out to be exactly the same level. So in whatever I have done till now, I have not really made any dilutions to test for something. But I remember reading results of a QC survey where making serial dilutions actually picked up a strong lupus anticoagulant, and the strength was so strong that it was sort of getting masked in the DRBVT initial steps. So
okay, I'm not familiar with that publication. I'll certainly look for it. But for the scenario you're describing, we don't make additional dilutions. One thing that does falsely give you a false positive lupus anticoagulant is an elevated CRP. So just keep that in mind if you have a positive, that there's good reason to retest 12 weeks later. But thank you for bringing that up. I'll definitely look in the literature on the dilution question. Yeah.
Thank you so much, sir.
Dr. Raju, do you want to handle these remaining 5 questions in the box?
Oh, yeah, sorry. Yeah. Okay. So D-dimer is not as specific as a test as sensitive in thrombosis. That is correct. It's a screening test. And depending on why you're doing the D-dimer, so if it's to DVT exclusion, you need a very sensitive test. So it's not going to be specific at all, actually. Because of the other conditions where a D-dimer can go up, bleeding, hemorrhage, thrombosis, surgery, there's a variety of things. Some D-dimer tests give you a false positive test with rheumatoid factor. So just keep that in mind. Since the pandemic, as you all know, with COVID infected patients, they have a very high D-dimer. And these patients that I've seen, at least anecdotally, they can have an elevated D-dimer for 2-3 years after their COVID infection. That's one thing to keep in mind. Then there's another scenario of a patient, they go in with a low pretest probability for a DVT, somebody does a D-dimer, but the testing is negative after that. There seems to be a fascination with repeating the D-dimer tests. And that just worries the patient. So I've seen a few consults, 6 months later, the D-dimer is still elevated. There's no cancer, they've had CT scans. Now what do you do? So, I mean, those are 2 scenarios that we encounter. So in pediatric, ASA is indicated when the platelet count is 1,000 or lower. I'm sorry, a pediatric aspirin. Is that what you mean? When platelet, okay. So that's a baby aspirin, but patient is symptomatic. So when you say symptomatic, patients with high platelet counts, MPNs, can sometimes present with the erythromelalgia, and aspirin is very good for that. So that is the one indication that you certainly can use aspirin. But that's where, okay, actually that reminds me, let me see if I can find my slide on the risk stratification for MPN. Let me take a quick look. I don't know if I'll be able to find it, but let's see.
Meanwhile, I'll keep Dr. Agarwal engaged. Sir, do you feel testing for acquired one-brand disease is necessary in our Indian setting when we were planning for aspirin prophylaxis in MPN patients? In your experience?
Your question for giving prophylaxis.
Yes, sir. One brand. Do you always work up for acquired one-brand disease?
No.
Right.
Never. Unless it's clinically indicated, we never do that.
Right.
Does anybody do that? I'm surprised by this question.
Because as per literature, it is being told that you have to test for acquired one-brand disease, the risk is there, those things and all. But in practice, do we encounter such scenarios? Like, have we burnt a finger, like giving, without testing, giving aspirin, patient has gone for bleeding in MPN scenario?
Oh, in MPN scenario, when the platelet count is 1.5 million and above, we are doing VWF recough. Yes.
Right.
That was the question. Acquired. Okay, fine.
Yeah.
I misunderstood your question whether before anticoagulation you screen for
No.
genetic disease in everybody. Yeah.
No, sir.
I misunderstood your question.
So let me just share one slide here. So this is my medical school version of the slide. And this is my understanding of the last the guidelines that if you have a thrombocytosis patient, you risk stratify. And if you are categorized in low versus very low, the thrombotic risk is equivalent to the age and sex matched control population. And there's no need for aspirin or cytoreductive therapy. So what's the definition of low versus very low? No history of thrombosis, young patients, you can or may not have the JAK2 mutation. So these patients can be completely observed over time. Then there's the high risk, any age, thrombosis greater than 60, and the JAK2, that's high risk. So that group of individuals does require some sort of intervention. And then you have this intermediate. I never know what to do with intermediate, so I usually ignore them. Now this is the at least the title that I showed you on Dr. Teferi's paper. He covers that in that paper, I think, quite well. So that'd be a good publication for you to get. Yeah. So I think that hopefully that answers this question on the baby aspirin. How do you approach post-COVID asymptomatic DO? Okay, I think I mentioned that. Do they need prophylaxis? No, they don't. The D-dimer elevations persist for a long time. We do not anticoagulate them. We don't even give them aspirin. COVID is, as you know, it's a really, it targets the endothelium, and I think there's a lot of endothelial derangement, and that's probably why the D-dimers remain up. Should we include PNH and hemoglobin S screening in routine thrombophilia panel? I don't think so. I think, so for hemoglobin S, it depends on the population. I think, at least in the US, the African population is a very high prevalence of sickle cell trait, We know that's a high risk factor of venous thrombosis. I don't know that you need to make it part of routine thrombophilia panel, but if you have a patient who's symptomatic and has had a DVT, you perhaps would look for hemoglobin S, again, population-based. For PNH, I really don't think routine screening is necessary unless there are abnormalities in the peripheral blood, hemoglobin, platelet count, whatever, pancytopenia. That's useful, or hemoglobinuria, that might be useful.
You consider LDH there, if LDH is normal or not normal? Screening?
I don't actually. That's a good question. So looking for low-grade hemolysis, right?
Yes.
Yeah. No, I haven't so far.
And about this sickle, you said sickle trait. You believe that is a prothrombotic condition, or it's all controversial?
No, I think it's been well shown, at least in the US studies and in African Americans, it's been quite well documented that it's a high risk for venous thrombosis. Now, one could argue that it's particularly in the hospitalized patients. So you add 2 risk factors and, you tip them over the edge. But yeah, that's a well-established risk. I don't know about the Indian population, though.
But there are reliable, good studies to convince you that sickle trait is prothrombotic?
Yeah.
And that's pulmonary embolism in situ, or it's DVT?
Both, I think. Both. Venous thromboembolism, right?
Okay.
Yeah. So experience in pediatric patient with inherited thrombophilia. It's a broad question. Do you mean management-wise? So the challenge with pediatric thrombophilia testing, I think we briefly talked about earlier, was reference ranges are not well established. Nevertheless, testing is done. So I would say that most venous thromboembolism in the pediatric patient is usually a provoked event, and therefore you may want to not do the thrombophilia testing unless there's a strong family history of thrombosis. And that would be important for like protein C, protein S, and antithrombin. Long-term management, it's frustrating because if you have a serious thrombophilia and if it's a 5-6-year-old that's got a serious clinical event, you're stuck with long-term anticoagulation. The good news now is warfarin. The bad news is warfarin was, not a good drug. The good news now is apixaban has been shown to be safe and effective, and rivaroxaban in pediatric patients. So I think therapy is getting better. Okay, let's see. Do we have more?
No.
Oh, okay.
The last one.
That was the last one. Yeah.
Fantastic. Lots of questions and fantastic answers. Any more questions from the people here? Not really. Okay. So, Dr. Rajiv Prathi, this was fantastic. Great lecture and a very elaborate question answer session. The faculty present here and the audience have asked great questions, and you have given great answers. Enjoyed it, and I hope you will accept our request in future as well. As I said, it will make a big change in the practice of people, and patient will be the ultimate beneficiary. Thank you so much.
It's been my privilege. Thank you again.
Bye. Thanks to RPG for supporting, and thanks to Kalpesh and Yash for managing the event. Bye. Bye to everybody.
Bye-bye.